Good morning, y'all. I appreciate everybody being here so bright and early. We don't have anybody joining us yet online, but we may because that was an option. I'm Katie Dempsey. Welcome. We'll begin this meeting today. I'll call it to order. Great to have the members here. It's good to see everybody in person. And I know a lot has happened since we last heard from DBHCD, a lot of updates and things. And so this is just a time for y'all to come and tell us your story and let us know what's going on and perhaps some ways that we can plan for January and help. Okay, so I believe Commissioner Fitzgerald, is that right? Is going to start us off. Welcome. Good to see you.
Let's get our technology up and working here. So I can see it, but oops. Is there a way that we can put the deck up here? I'm seeing it here. Michael, do you know? Or is it, there we go. There's me, there's us, here we are. So good morning and thank you. It really is great to be in person and we're glad to take advantage of the opportunity for really what I hope can be in this less formal context, a conversation. We came, as we often do, with an abundance of information, but what's more important to me this morning is that we update you and tell you a little bit about some priority areas, but also more importantly, that we answer any questions that you have. So we've got a full slide deck here, which we will have available for you. Or do they have it yet, Michael? You do. Okay. So you see, you've got lots of information, but more importantly, I'd love, while you've got experts here, we'd love to be answering your questions and making sure we are clear about priorities, challenges, and things that are happening in the world of the Department of Behavioral Health and Developmental Disabilities. So again, thank you for the opportunity to be here. What we thought this morning was that we would try and cover two main topic areas. These are both really important to us. The first one is 988. Okay, and I'll give you a little framework and context about that in just a moment. And the second one is we wanted to share as much information as we could about how DBHDD allocated the federal COVID relief and ARPA funds. So and we can give you a little bit of our rationale for why we allocated the funds that we did, how we made those selections in a very expedited process that you all are aware of. Decisions had to be made quickly. What our hope is in sharing this information is we can show you how federal dollars were spent so that you know some of the areas that are covered, so that as you all are thinking in this time where we are so appreciative of the increased interest in mental health, but that you all know federal dollars that have been put on the ground and we don't duplicate things that the feds allowed for us to spend, and you all understand where some of the gaps and challenges still exist. So we'd love to talk openly about that with y'all. So you will have in your possession very detailed information. As best we can, we're just gonna try and give you highlights. So now let me get back to the first area that I said that we were gonna share some information with you about this morning. And this is 988. So if I'm using that number, I don't know if it's familiar to you yet. I previewed it last year, but last year seems like a really long time ago. But 988 remains. So I want you to just begin thinking about 988 like you think about 911, because this is a national movement. It is, in fact, federal law that was signed under the Trump administration to designate the three-digit number 988 as a three-digit dialing to reach the National Suicide Mental Health line, suicide prevention line. Okay, so every state is doing what Georgia is doing right now. And you're going to hear a little bit more about how this looks in Georgia, how we're preparing. But I just want to say a couple of things about this. We are preparing, as the law says, that this three-digit dial 988 will go live in July of 2022. That is, in fact, what the law says. We have no reason to believe that it's going to be anything different than this. This is a huge lift and a really big overhaul. In my time in the behavioral health field, which is now spans decades, I'm proud to tell you, I really believe that this is one of the most transformative moments in behavioral health. And I do want to remind you, when I use that term, behavioral health, you're going to see the term mental health in some places here, but it's really important for me to be explicit. When I say behavioral health, what we are talking about is mental health and substance use disorders. Okay, so mental health and addiction, when we use the term behavioral health. While those services sometimes are delivered separately, what we know is that people in crisis often are experiencing both mental health and or a substance use crisis. Okay, so I'm trying to be explicit about the language. I want you to know how we think about it and how we're planning for it, even though the national conversation has actually not yet quite been clarified by the feds. But we know what we know in Georgia. And then I don't know if y'all have had a chance to see the headline in the paper this morning. Lead story in the AJC was came out of national reporting yesterday. The highest number of overdose deaths in the country yesterday, over 100,000 deaths, primarily driven by opioid use and fentanyl, as well as meth. These are really, really serious concerns. So when we say behavioral health, I really do want you to know at DBHDD, we're incorporating both of those. It's mental health and addiction, but where we mirror the federal language, they're still looking at it as the National Suicide Prevention and Mental Health crisis system. So just a little bit, I want to, again, try every time I can to be as clear as I can. So this number 988, I have brought with me this morning, as I like to do, some experts from my team. They're the ones leading the efforts that we're going to talk about. So I'm going to invite Debbie Atkins, who is our Director of Crisis Coordination. She is a nationally renowned expert, and she is leading our team internally at DBHDD, but you'll also see how we're partnering with several other critical agencies and individuals and groups that are going to be heavily impacted by the implementation of 988 as well. As you can imagine, for example, our partners at 911 are a really important part of this as well. And again, just to set the stage, 911 folks around the country are really happy about this, as you would imagine. They would prefer that a mental health or substance use crisis is handled by someone with expertise in this area. So that's, and so joined together, 911 is saying this will be great. There's a portion of the calls that come to 911 that we'll ultimately be able to peel off and hand to people with expertise in mental health and substance use. And we agree. We would like to be stepping up, and Debbie's going to tell you a little bit about how we're already preparing what we have in place in Georgia, which is far better than most states. And I really want to make this the final point I want to make before I invite Debbie up, is the reason that's true is because of the investments that you all have helped made over the last decade in our crisis system, right? Partly by virtue of our settlement agreement with the Department of Justice, but the state of Georgia agreed. We did not have enough community-based services for people at the highest level of need in our state, in the community, right? That settlement agreement said we were over-reliant on our hospital services. Let's build community services. Over the last decade, you all have invested, and really I have to just commend the DBHDD team and our providers who stepped up, and we do have a fairly robust crisis system in place in this state. So you're going to hear how that's the foundation of where we're starting, but you're going to hear how we need to accelerate our planning of what's ahead. So you see the basics on this single slide, and then I'll invite Debbie to come get into the details here. What is 988? It's that national 3-digit dialing that's going to connect you to a suicide prevention line. Now, and come on up, Debbie, because then I'm going to let you go from here. Here's the good news. What we want is for a person in Georgia to be responding to that call. They already do that. Debbie will explain a little bit about that. I'm going to come over and sit right at the front desk here. So if there are questions as we go along, here's what's most important. We want to be as informative as we can and answer any questions that you have along the way. So I've asked Debbie, just pause along the way so that you feel free to ask questions. And then I just want to be mindful of time for those of you that want to get to Monica's presentation about how we're using the federal dollars. We'll just manage our time in a way that I'll look to you, Madam Chair, for if you feel like you want to move the conversation in a different way. Okay, so with that, Debbie Atkins, our Director of Crisis Coordination.
Thank you, Commissioner. Thank you, Chair Dempsey and committee for having us. So you'll see that this is saying that it's still going to come to GCAL. That's a great thing for us. We're very excited to know that we have one call center in Georgia. There are states that are managing 10. Some of them are volunteer. You can imagine the logistics of trying to figure out how those calls go. So for us, we're really excited that we've already established that. We know we've got some work to do, but we've established that one call center. So just for logistics, when someone dials 988, it pings to the National Suicide Prevention Lifeline, and based on area code at this point, not geolocation, area code, it will come to the Georgia Crisis and Access Line for anyone that has a Georgia area code. We're still working with the feds. They haven't pushed forward with geolocation at that level. So we know that we will still be dealing with individuals whose kids are in college, or if you kept your phone, that type of thing. So what we had to focus on, starting last year, we really looked at the law. We delved into the three main issues that are in the law. Someone to talk to. Someone has to answer the call 24/7. Georgia already has, thanks to y'all, the text and chat line. We do not do national suicide prevention text and chat because it is on a platform that is not integrated with our system. So they couldn't see, oh, you have insurance or you're enrolled with this provider, that type of thing. They can't dispatch mobile if something got to that level and really needed someone on site. But we do have text and chat for Georgians. We have peer run hotlines that we actually do warm handoffs to our peer hotlines so that they can talk to people who need to talk longer. And so that we have mental health and substance use. And that's something that we do have now. We're trying to strengthen in this process. And then someone to respond, mobile crisis. Like Commissioner said, we actually do have mobile crisis statewide. Do we need some improvements? Do we need some things? Yes, but we have the framework for that. Coordinating with 911 and EMS, we already have the ability to transfer to 911. What we're working with Michael Nix and his team to do is to figure out how to make that reciprocal to where they can transfer to us. We're looking at a lot of things with them, and they have been incredible partners with GECA. And then our outpatient community provider response. So you know that we have the ability to transfer to our providers if they're with a high-end service, that type of thing. And then somewhere to go. For Georgia, that means our crisis stabilization units. For us, you know, the behavioral health crisis centers are the primo, right? You've got all the different components. Police can drop off, people can walk in, all of that. Peer wellness and respite eventually will get built up across the state. Detox centers and the capacity for detox will be built up, and then our inpatient beds as well. This is how we approached it. We have a steering committee that is part of our executive leadership and key functions across our department, you know, things like finance and, you know, this team is all a part of it. We have leadership in all of the areas that really help guide it. We have a coalition, and I'm going to do a slide next to let you know the multiple partners that are in the coalition, but I'm not going to read them off. You'll just see the depth of it. And then we have work groups and separate meetings that we've done for like planning coalitions and feedbacks. The coalition you'll see to the left, it is a wide array, and we had incredible participation. I cannot say that I was able to get sheriffs and police officers and hospitals to a table for 2 hours once a month. It was incredible. It was invaluable feedback to us. A lot of the things we heard, we knew. but the fact that we could really take what they had in a creative way and feed into what our planning was just incredible. We've now added many of them to our work groups, right? So the coalition last met at the end of September, and our plan is to use work groups through October, November, and December to do like the nitty gritty, right? Not the high level. Let's really get more plans on the table. And so they're actually joining those work groups. And as we move from work groups back to a final draft that goes to SAMHSA in January, we'll move back to meeting the coalition again, making sure they're okay with what all the subgroups worked on and things like that. This is the current investment that you have made in DBHDD's crisis system. The call center and mobile crisis, y'all know, has a little bit of federal funds in there. We do some administrative matches, but the $193 million for our CSUs, BHCCs, and state contract beds, y'all have been very generous in helping us grow those programs and solidify where we are now. And so we're very thankful for that. This is our current volumes. So this year, it was a 24% increase in GCAL's call volume. We had 275,000 calls. We had 20.4 thousand mobile crisis dispatches, even amongst the COVID restrictions. And we continued to serve 32,000 people in our crisis stabilization units in our state contract beds. So we've been busy throughout this, even with limited bed capacity and shutdowns due to isolations and quarantines. We've still served quite a few people. So these are our projections, and we want to know how we got there. We looked at the current call volume. We looked at projections that both SAMHSA and Vibrant, who runs the National Suicide Prevention Lifeline, they told us to expect an anticipated 7% increase. Now they had a low, a moderate, and a high. We went with moderate, right? Because we're already established as a statewide call center. We didn't want to overestimate. So we looked at what we had in Georgia. We looked at what percentage was from the Suicide Prevention Lifeline. Right now, Georgia has about only 25% coming from there. So we added the increase for theirs. We applied the increase to ours, and we came up with 564,000 calls. So just notice that's double, right? That's double our call volume right now. From there, we know that 10% of all calls run into mobile crisis dispatches. Some of them are completed, some of them are not. So that's kind of how we got to our mobile crisis numbers and projections. And then the somewhere to go, what we decided to start with is to shore up the gaps that we knew we had right now. Some of that y'all have seen in other things. So the 3 new adult BHCCs, that's Metro Atlanta. Y'all have been begging us to look at Metro Atlanta. Those are things that we have put in for that. We talk about our BHCCs. We still have 10 that are really not converted to true BHCCs. We want one system, everybody to have police drop off, everybody to have walk-in centers, that type of thing. And then enhancing 2 of our kids units and then placing kids units in the 2 regions that did not have them. So it would take us up to 6. And the main reason for that is to really transportation for families, right? They complain a lot that their kids have to go zigzagging across the state. So we're hoping that this plan will be something that we can move towards and accomplish. Now, again, these are projections. We're going to be cautious because we want to be really good stewards of your money and of the state's money. And while we're still planning, and you'll see when Monica comes up, we're using federal dollars that we have to enhance where we can enhance. We want to look at the first quarter of next year. Y'all remember 911 came out in the 60s, and it took 3 years for them to see the increase that they saw. Now we know times are different, right? More people are included into technology. What we don't know is how the federal government is going to market this. This is going to be a national campaign. So it could be slow. We want to see if our projections are right. And by first quarter of fiscal year 23, we should know, hey, it's either ramping up very quickly or it's not. So you'll probably hear from us again then. This is the impact that we're looking at. We know that we're going to have to answer calls, texts, and chat, and that's going to increase. We are expecting a ruling by the end of November on what the definition of follow-up calls is going to mean for the call centers. Georgia does it a little bit different right now. The person who follows up is the highest level of service. So if you're in a hospital, it is the hospital's responsibility to follow up and say, did you make your appointment when you discharged? Were you connected, right? They're wanting the call center to do all of that. And that will be a transformation for us that we've got to think through and plan through. But again, the federal government has been really slow to give us guidance on what they mean with some of this. So while the timeline is ticking, the guidance has been really behind. These reports were due out last April. And we're in November. Yes. So we're on calls regularly. We were told on a call with SAMHSA yesterday that it will come out by the end of the month. We were told, to your point, Commissioner, on mental health versus behavioral health, that yes, it says mental health, but crisis is defined by the individual. You will get calls from all sources and you need to be prepared to answer them. So that was the most they've given us on clarity for that point. We have to coordinate with our community of care, right? So we have to figure out how our call center at GCal is making sure that everyone is connected. So that's broadening. You know, right now we have geared GCal towards our covered population. Anybody can call, but we've had a lot of, you know, we'll transfer back to an insurance company because we don't know if that insurance company covers, you know, this psychologist, that kind of thing. So we need to make sure that we have a better connection there. And we're working on that. We have a public-private partnership group that's looking at that. And we're going to have to dispatch mobile crisis to a higher volume. We're looking at technology. We're looking at creative ways, and that's someone to respond to extend our mobile crisis. We know that there's a hiring issue in Georgia right now for professionals. So how can we work smarter, not harder? And how can we document responses? If something ever does come down that we could bill Medicaid for that, you have to be able to have a note that you can tie to a billing. And so we're trying to think ahead. How can we change our technology? So down the road, we might be prepared for that. And then somewhere to go. We told you the different things that we're looking at, converting to BHCCs. It's really important for our sheriffs to be able to have the capacity to drop off and not take to an emergency room. Temporary observation in areas that we've been able to truly use it has been incredible. We're seeing a lot of diversion and work to keep people in their communities, to keep them closer to home and out of hospitals. And that means, you know, kids aren't going to foster care. Mom's coming home, mom's keeping her job, that type of thing. We want to increase our recovery supports and our capacity in the beds as well. So from that, this is the fiscal. What we will say is, because Georgia has been doing this for a long time, we're able to pretty accurately tell you what it will cost to live up to our projections. So we know what we spend with GCal now. We know staffing wise and technology wise what we need to do in order to double that. For mobile crisis, the same thing. We know how many teams are out there. We know what we have to do. We know that we're going to have to increase their technology. We're going to have to add in some supervision from telehealth means, different things so that more teams can go out. And so we know what that cost will be. And then the somewhere to go, you'll see some one-time costs. We're really good at getting to y'all the projections for how to build a building. But we did change our model a little bit on the ongoing costs for these units. We looked at our staffing models. We looked at our key performance indicators and looked at how we would have to change our model, even with the existing ones, in order to meet the need. You got to have more people if you want more people coming in, right? You got to be able to give them the attention so that crises don't happen in the front lobby. You have to be able to meet them and give them hope where they're at. And so that means more staff. And we know what that costs. So these numbers are projected based on the projected numbers that we say will happen. Again, we want to give it the first quarter next year to say, yes, it's living up to what the federal government's saying and what we're doing. But this is showing a one-time cost of the $148 million for the new buildings. And, you know, we can always go into detail if y'all want more detail as far as what those buildings are. And then the projected annual cost is really staffing. Okay.
We have a question.
Okay.
Can I interrupt just a minute? Representative Oliver.
Thank you. This is very helpful. It's also very complicated. And
It
I'm
is.
trying to follow you all. You're spending 14 million right now on the existing GCAL. And is that call center in one location or is it physically all across the state?
So physically, they do have a call center, but they're working remote. And so they have learned that they can set up remote connections to make hiring easier. And so we've invested in that technology through COVID to allow them to convert and have that call center available. So you can be located anywhere and we can still hire you. They put the technology in and they have the support through that technology for supervisors to still be able to see.
Is that an example of how you were able to use COVID money, that you were able to buy that extra technology? My confusion, and this is not something my confusion is not going to be solved today, but I'm really interested in preparing for our next budget cycle. How much money did COVID come in and how did you use it? How much money is on the table that you have applied for in the Rescue Act money, if any? And thirdly, what we'll know in January, that you have made a budget. The governor told you not to ask for money. Is that correct?
Flat budget, yes.
Flat budget. And yet there's $3 billion of reserves and $4 billion of Rescue Act money sitting in a bank, sitting somewhere. And I can't put it all together in my head, how that works. Specifically, the 14 million that you have right now for the GCAL employs.
That's stated appropriations that came from you.
And it employs, that is the physical technology, the physical call center, and the employees. And that needs to double, basically.
That's what we're projecting. And we did use, and you'll see in Monica's presentation, we did use some of our mental health block grant, actually got a crisis set aside.
And the federal money, what federal money comes with 988 that's going to help you double
We're
the
still
14
waiting.
million?
We are still waiting. Right now, the federal money has been earmarked to go to Vibrant. We found
Go
out,
to where?
yes, to Vibrant, who runs the National Suicide Prevention Lifeline. So what we found out yesterday afternoon, new for my team, I was on a call late yesterday afternoon, and Vibrant announced that in President Biden's new bill, there is $288 million coming out. Some of it is renewable and some of it is one time. The 177 million is going to Vibrant for them to build their infrastructure out, and that is the renewable dollars.
Is that going to help us at all?
That remains to be seen.
Yeah.
I think
Doesn't
it's
sound like it.
Right. So it's a complicated time. I'm happy to, in this environment, just talk about how frustrating it is to
And Madam
have
Chair,
lack of clarity.
I
from
don't
the
want
feds.
to
Yeah.
try to solve all this, but because it's way above my head, but at some point, you're going to have to figure out what pot of money is going to pay for this.
Yeah. Can I say two things? So first, I think it's going to be really helpful when you hear from Monica about what we did do with the funds we received already, how those are hitting the ground, what they're being used for, what the feds directed, and then what we decided. So I do want to get to that. The second point, I do want to say, we are still in conversation with OPB. While it was a flat budget instruction, we were allowed in our budget presentation, when we presented our budget to the DBHDD board, we were able to talk about other priority areas for DBHDD, should there be consideration of other funds. So we laid out a number of other priorities and issues, some of them related to crisis services. So there's still conversation happening.
And the conversation, and then this will be my last, Madam Chair, and then I'll hush. You're going to try to coordinate 911, the federal 988, and your existing GCAL system.
Yes, ma'am.
Okay.
So 988 will come to GCAL. They are the only approved call center in Georgia. We already have that connection.
And that's 24/7 and it includes texts and chats.
Text and chats do for 988, no, because
But
they're
it does with GCAL.
It does with GCAL.
Yes.
And we are hoping that Georgians will still use the app and the funding that we have for our mobile crisis and text and chat, right? The national platform is something that is ongoing discussion. Vibrant would like to, the National Suicide Prevention Lifeline would like to control that platform, and they want you to go through them to do text and chat. Again, we're integrated. We're a little bit further ahead, right? So, with our ASO, when GCal calls, we get to see everyone's history. If Chair Dempsey texted in, we would know her text number and that she had called before. If she had ever had an episode, it would pop up and say, this is Katie Dempsey, and she's enrolled with. So we have the ability to really do good work for Georgians, and we want to keep that. That's very important.
Thanks, Debbie. Can I add just one element of this again, because this is an ongoing dialogue with the feds. Georgia, because we are considered one of the most advanced states in terms of our crisis system. Again, that's because what you all have helped invest over the years. So at that top tier, we have banded with some of the other states who are like us and would like to say to the feds, please don't take us backwards. Your current plan takes us a little bit backwards. So all of this is very active dialogue that Debbie, that we are in partnership with a handful of other states that are at this level of preparedness.
We have one more question too. Thank you, Representative Oliver. Representative Donahue.
Thank you very much. Just a few questions. When I'm dealing with DOL, DOR, it seems that it's a nightmare for people to get through to talk to a person. And it seems like that's something that I've had quite a few people talk about you guys.
Yes,
and with it, it's not to always label that everybody's bad, nobody does their job. It's just a lot of people don't. And with that, we're paid a lot of money to do follow-up on that job. I think it's $15,000 a year. I do it to serve my constituents. The question is training. How much time do we spend training the people that work, that answer calls, that file paperwork, that do applications? Because it seems like quite a few people keep reaching out to me that deal with this on a daily basis. There are a lot of problems, and the application process needs to be a little bit simpler.
Can you clarify applications for?
You know what? I had one friend had sent me this because I told him we talk about it all the time. And then when it got to about 10 friends that deal with this every day, I said, we're going to discuss this. Application, let's see.
Just want to make sure I'm answering the right question.
Well, and you know what, and I apologize, but the application process will maybe the kids that are not being filed, submitted correctly. Let's see here,
So
application.
it's probably an application for the psychiatric residential
Right,
treatment
where they're at a
facility.
certain age, they are out. There's a certain age that I know we're talking about all the time that they're not.
It's something else. So this isn't part of the crisis system. This is something about aging out of foster care.
That's another one of the questions that recently I have heard nonstop. So I guess it would be application would be confused with me asking because, I'm talking to so many people about the whole process.
And it is complex. And that's why I'm trying to stay as high level as possible. The call center, we do a large amount of training. We have restructured the call center a lot in the past 6 months to help answer calls quicker. We are adding technology for known numbers. So we are allowing sheriffs who need things, hospitals who need things to do some things electronically instead of having to wait in queue so that the call center can really focus on individuals. And you'll hear from Monica, some of the funds that came through our national block grants and COVID and ARPA funds went to increase staffing. Again, we had a 24% increase this year. And so this week alone, I know that 27 offers were made to help fulfill some of those dollars. We met with GCal this week. So that's great news that they got 200 applicants, 27 of them were given offers. And so they'll go into the training process. So we are confident that the structure we're putting in place will get the results. We just need to give it time to get people hired and to put the system in place.
Now, let me ask, here's how I handle the problem. Instead of starting down the ladder, I go to the top. I'm going to always do that. I do not have time to play the games that
I
so many
understand.
people do. So hopefully we have your cell phone numbers.
Absolutely.
And I want to make sure of that because my time's getting very limited with all the nonsense we put up with. So with that, what I will do is make sure I have those. And I will never call to ask what you had for dinner last night. But when I call, it is serious and very important. Thank you
Yeah.
very much.
Thank you. And I don't want to leave your question hanging because there's one aspect of the work that DBHDD does that we did not bring to talk about today. And when you mentioned the word application, I also wonder if some of your constituents might be talking about people with intellectual and developmental disabilities. So yeah, please note that's a different area of our work. We didn't bring that today. Be happy to come and talk a little bit more about that. But that would be an area. It's financed and arranged differently. And for individuals who would like to be considered for a waiver, that would be where you would make an application through an extended process. And as just to make a point, as you well might recall, you all fund waivers for individuals. We have almost 14,000 people on waivers in the state right now. And we do have an extended planning list. When an individual receives a waiver, we, the state of Georgia, have essentially allocated a lifetime of services for that person that the state is paying for. So it is in fact a comprehensive application process. Again, as we want to be responsible stewards of those funds, we should not make the administrative part hard. The challenge is how would we pay for a lifetime of services for complex individuals? I'm always happy, as our team is, to receive a call about a constituent who needs more information and wants some help and hand walk through the process.
This is just an overview slide. I'm going to finish so that Monica has time, but this is really looking at, we really do want to go back to first quarter of next year. What are the numbers in reality? We're looking at many different options for funding, and they're listed here, but we will continue to work with you. We will continue to update you as we know things from the federal government and what's available. Right now, while we're on a timeline, again, they just tend to think they can keep pushing it out some. And so we're hoping to get information and be able to come with more clarity once some of this plays out on the national level. And Monica, I think it's.
Any other? So today really was intended to be a preview because this 988 obviously is going to be a very active conversation in the coming months. Just getting you started. Please know you're going to hear lots more, but we're always happy to take your questions. If there's no more questions and you're interested in pivoting, I'd like to invite Monica Johnson, who's the director of the Division of Behavioral Health, who really led our department's efforts around money that came in fast and furious from the feds with a lot of strings attached, as you well know, and how are we going to meet the needs that we can with these dollars and as quickly as possible, get them on the ground to do the good work that we all want to do. So Monica.
Thank you, Commissioner. Good morning, Madam Chair. Thank you, committee. So I'm going to speak, Debbie spoke about crisis. My conversation is going to be much broader around behavioral health spending related to these federal dollars that we receive. You have the presentation in front of you. For the sake of time, I'm not going to hit every single bullet that is in my presentation, but I'll answer any questions along the way or afterwards. So obviously what we do know is that there was an impact from the pandemic, from the COVID pandemic on not just our physical health, but our mental health. And that includes, as the commissioner referenced earlier, our mental health and our addiction services. So we've seen upticks across the country as well as in the state as related to the, I consider, pretty devastating impact on people's mental health. So here what you'll see is we've seen nationally an increase of about 370% of individuals getting daily anxiety screenings. Daily depression screenings went up by about 394%. And the number of Georgians taking any of the screenings, either of the above that I referenced, up by 426%. So those are pretty significant statistics. We've also seen an impact on substance use. The impact has marked a very marketed impact on individuals' use of substances. This has been seen nationally as well as locally here in our state. What we do know is that overdoses have increased up to 42% per month. And these numbers are, I want to say, they're static. I mean, they're fluid. So what you may see today in these percentages can be different tomorrow and it can be different next week. But we know that these trends have been upward consistently throughout the pandemic. Fentanyl use has increased by 32%, meth by 20%, heroin by 13%, and cocaine usage by 10%. Alcohol sales in retail stores increased by 21%, while online purchases of alcohol increased by 234% when compared to the pre-pandemic period of 2019. And I will just say that when you see that type of uptick in the purchase of substance use, people may say, well, that doesn't equate to an addiction. But I will say anything in excess, you're moving closer to that. So it's important to monitor those sales. So what happened was the federal government released a bunch of different pockets or buckets of funding related to COVID. I am only going to talk about the bucket that DBHDD was responsible for receiving and managing, and that is through the SAMHSA, Substance Abuse Mental Health Services Administration, so our federal partners. That money went to SAMHSA. SAMHSA has what we call block grant funding. Block grant funding goes to every state and territory in the United States. So each state gets a different allocation. I'm going to walk through with you what those allocations look like. There are 2 block grants that we get. So put COVID aside for a second. Without COVID, we get these dollars anyway. There is a substance abuse block grant, and there's a mental health block grant. There are 2 different overseers. There's different project officers on the federal level, different due dates for reporting, but we're getting them both within our department. Because states already have a venue, there's already rules, there's already a process, there's already the infrastructure. A lot of the COVID money that was approved at the federal level through the Trump administration's CARES Act and through President Biden's American Rescue Plan Act, they decided to use the money that was to be targeted, some of the money that was to be targeted for mental health and substance abuse through these existing block grant infrastructure tunnels already in place. So what we then received was 2 influxes of additional federal funds in addition to what we already get. So I'm going to walk through those now and break them up into 2 categories. We'll talk about substance abuse block grant first. So the amount that we already get right now for substance abuse block grant, not counting the supplemental funds related to the COVID pandemic, is $57 million, a little over $57 million. The CARES Act introduced $53.5 million new dollars of supplemental funding. The word supplemental should be bold and underlined. What it means in this case is just what it sounds like. It's temporary. So it was an added boost to help address, in this instance, because we're talking about the substance abuse block grant, to help address needs that may be as a result because of the pandemic. So you saw me reference the impact in some of those percentages. I think I heard some when I said some of those numbers. So these dollars were to address what is known to be a national challenge. So when you put money through the block grant, although it was supplemental, which means time limited, there's a 2-year spend cycle. You have to spend the money in 2 years. I want to give you a couple of nuances that are important for you to understand about that money. The first thing is that because it's through the block grant has some rules. So there's rules, like one of the most important ones, they're community-based. So whatever you apply the money to must be for community-based substance abuse mental health services. So you can't use it in a hospital. So DBHDD has a hospital system, as you all are aware. We could not use any of that money to help with some challenges that we had within our hospital. There are a lot of other nuances and rules. So while we were very happy to receive the money, we had to still operate within the structure of that first column of the $57 million. So the $53 million was given to us from the CARES Act. And so when we got notification that, hey, DBHDD, Georgia's getting 53 million, we had about 3 to 4 weeks to turn around what is called a spend plan. So it's basically the state's answer to, here is what we're going to do with this supplemental $53 million. That spend plan has to be approved. We have to await approval for that. The general wait time was around 6 to 8 weeks. So waiting to get that approval. We have since obviously been approved for that money. The second bucket was the American Rescue Plan Act. We received another 46.2 million, again, supplemental temporary 2 years funding. So that was a total of $156.8 million that we received within about a 6-month period. You'll see here that under the CARES Act, I referenced that both of these fund cycles have 2-year spending plan cycles. So the CARES Act, we have till 21 to 23 to spend that money. And then we have from 21 to 25 to do the same. The caveats with both CARES and OPERA, which is different from our general, that first column, our general block grant money, is it had to be, you're making a difference and it is answering some of the challenges that you are having as a result of the COVID pandemic. When I talk about rules related to the block grant that we still had to adhere to, even though we got these supplemental funds, each block grant has set asides. So the federal government already outlines what it is that we have to do with certain percentages of that money. So for substance abuse, we have a 20% primary prevention set aside. So no matter what else you do, you take out the 20% off the top. It has to go towards prevention. There's a 5% set aside for HIV, and there's a women's set aside, women's treatment funding set aside, and that is a little bit different in how that's calculated. It's not a percentage, it's based on historical use. So that's substance abuse. Then we also received at the same time, mental health supplemental funds. So again, following the same logic as the substance abuse slide, the first column, you'll see that our base amount that we already get annually is $23 million for mental health. When I say for mental health, that is divided between adult mental health and child and adolescent mental health. For CARES, we received $26.4 million in supplemental funds. And for the American Rescue Plan Act, we received $45.6 million. All of those, again, following the same logic, supplemental funds. That was a total of $95 million for mental health, children through adults. Same 2-year cycles as you saw on the substance abuse side. There are set-asides related to the mental health block grant that are different than on the substance abuse grant substance abuse side that you just saw. So the set-aside here is 5% for crisis services. So some of what Debbie talked about, some of the enhancements or adding staff, as she talked through some of the 988, we put some of that in our set-aside requirement for our block grant. And then there is a 10% set aside for what is called first episode psychosis. So it targets individuals that are transition age, emerging adults, ages 16 to about 26, that are experiencing their first psychotic breaks. And this money helps support specialized programming for that. So all of that still had to be accounted for as we develop these spend plans. So because this funding came to us through our block grant infrastructure, There is one requirement that is necessary whenever we develop any spend plan related to a block grant, and that is to work with this council that you see at the top. So Georgia Behavioral Health Planning and Advisory Council is a required entity. If you receive federal SAMHSA block grant funds, you are required to have a planning and advisory committee that has input, that helps prioritize what you put forward in that block grant spend plan. So because this was so unprecedented, the amount of supplemental funds that we received relatively back to back with an extremely quick turnaround, at least on our end, we decided that we wanted to seek input from other partners other than the required planning and advisory council. They're a key partner. We value that relationship, but we wanted to also hear from other voices. So we sought input for the plans that we put together from, we have a behavioral health provider advisory council. We have the Community Service Board Association. We have the Supported Housing Advisory Committee. And then we have an interagency directors team that is the state system of care for children. So we went to all of those different entities to solicit input into what things did they feel like would make a difference from their perspective. A lot of these committees have peers on them. They have consumers, they have other state agencies, other providers. So it's a very eclectic way to seek input about what could we put in these plans. What I believe you have in front of you, in addition to the slides, is you have the actual spend plans. So you have, yes, the full spend plan. So you can look through those and you're able to see everything that was approved. So if you're looking at it, it was approved. If it is from the CARES spend plan, those things should be 99% encumbered, meaning we have put that money into contracts. It is with providers. It is with whatever entity was to receive it. Opera funding is probably closer to 60% out into the street because we just got approval for those within the last couple of months. So I did want to highlight a couple of things, and I'm mindful of the time, so I'll probably just hit one so that you guys can ask questions from each one. So some examples of some of the things that we did for substance abuse, we expanded our addiction recovery support centers. These are peer-led centers where individuals can go to help them in their treatment and their support. These are very popular. We love these, so we got to support those. We did a little bit of expansion for some community residential for substance use, and we did some expansion for medication-assisted treatment, which is a combination of medication and therapies for individuals with opioid or alcohol addictions. For substance abuse, for the opera funding, what we decided to do, and you will see this in some of the plans when you have time to go through them more, because these came back to back, CARES first, opera second, 2 years for each, where we could continue something we started. In the first one, we would pick that up. So you'll see some places where you may see like, why did they put this in 2 places? Because it's time limited and we have to think about how to sustain. And that's a really key part into our planning, is plan something that you can sustain or have a good plan to do so. So you'll see some of that. We help support some detox expansion beds, which is really important. So I wanted to highlight that. On the adult mental health side, from the CARES funding, we added a jail in-reach program. This was basically case managers that work with providers in the behavioral health world in the community to help coordinate individuals that need behavioral health assistance transitioning to the community. Co-responder programs have become very popular in our state. We have started to help support some of those programs where a police officer is responding, so they receive the call, they're responding, they have a clinical support to go out to help answer those calls. Very popular. And then in the opera one, we did an AOT pilot enhancement that is actually underway now. And then you'll see addition of some mental health court programs, treatment court programs. For children in the CARES program, one of the things I really love is the APEX internship program. Many of you may be familiar with APEX, but it's our school-based mental health program. And we have workforce challenges in this state, as most states do across the country. And so this is really important to us because it helps build a pipeline for it to keep the APEX program going. Oh, I did that faster than I thought. I'll give you one more. Intensive customized care coordination is something that people often don't get to hear about, but it is a very high level of care for youth with serious emotional disorders. It helps keep them in their communities, and it provides what we call high fidelity wraparound. High fidelity wraparound basically is come up with every service you can think of and then be even more creative in that and figure out how to help support the family where the youth is. So we're expanding that program.
And I'm just going to add one thing while y'all think about what your questions are for us. And there's lots for you to absorb in there. I'm sorry to throw so much at you, but I'm happy for you to have the full spend plan. As Monica said, as you can imagine, the work was pretty relentless for a couple of weeks. But we're grateful. These funds are really critical to solving some problems in the state. I hope you did notice across the board, while we couldn't make permanent enhancements to pay workforce rates, we have allocated a fair amount of funds to workforce incentives. So in every area, both in substance abuse and mental health, you'll see that we're putting a lot of dollars on the ground to incentivize hiring and retention bonuses, things like that, that providers are probably talking to you about. They're certainly talking to us about. And so those are important dollars that are getting put on the ground across the board. So I just wanted to highlight that one as well, because a theme that you'll be hearing from your constituents and your businesses, right? Because providers are your local businesses. They're going to be saying our workforce challenges are really big and crippling in some ways. And can we have help? And the supplemental help we can give them right now is some of these funds through supplemental and incentive pay. So we're getting those out on the ground quickly as well.
Thank you, Commissioner. That was a really good one to highlight. And what I'll point out when you're looking at the spend plan, what you're likely to see is, using that one as an example, workforce may be on the substance abuse one, it may be on the children's, it may be on the adults. That was calculated and on purpose to get more for our bang, more buck for our bang for our buck.
There you go.
It was coming out one way.
But we'll take more buck for our bang too.
Exactly. So we try to work together and collaboratively internally as well across our disability offices to see how could we really try to capitalize on this opportunity to get more out of that. So that's all I have, Chair.
You got a lot of paper
Chair.
behind all of
No,
that.
no,
And-
y'all, you boiled that down very succinctly, and I appreciate it. I mean, we've known you were doing a lot, perhaps not quite as much were we aware of, but this is great. And it is, I think one of the greatest challenges is when you do receive money, how best to most wisely decide to invest it for as long a term value as you possibly can. So I appreciate it. I know y'all have worked and should be tired, and there's more work ahead.
There is.
No doubt. There really is. Are there any questions or comments from the committee members? So Chairman Oliver, please.
Just to get in the weeds just a tiny bit, something that I'm confused about, additional thing I'm confused about. The Mara Group program provides Medicaid for foster care children, and other families not in the foster care system have Medicaid. And we still have, I don't know how many last night, but a good number of children, foster care children in hotels. How, because of, generally speaking, because of difficult to place, difficult mental health issues. How do you coordinate with the Mara Group people? How do you make the systems, multiple systems work? to find a solution for Georgia's foster care children being in hotels?
Yeah, I'll start. Monica will help reinforce. So for us, yeah, hoteling of any youth is unconscionable. I think it is a critical problem the state should solve. So DBHDD is actively at the table with our partners at DHS and DFACS, Department of Community Health, who oversees AmeriGroup, and AmeriGroup. In fact, we had a large call with everyone on that virtual line last week, really trying to drill into some of these complex cases, because in fact, they are complex cases. So for DBHDD, one of the things we recognize, and with the two new commissioners that have come to the table, really also everyone ready to roll up their sleeves around this. One of the things that's been important to do is to clarify roles and responsibilities, who has what expertise and who has what responsibility. Because I do think it's important for AmeriGroup, who the state has made significant investments into, to embrace their responsibility for access to the care and the coordination. DBHDD does have a role to play here as well. One thing I should mention when we talk about this, and it's a countable number of youth, so we should put our eyes and our hands and our arms around them and really think about, there's a longer term question about how did we get here? There's the short term question of what do we do right now?
How many are in the hotels this month?
We received a list, but I don't, this is DFACS would hold that list. We received a list of 40 individuals. I can't say for sure that's the full list. That would be for Commissioner Brose to affirm. But I think that's in the ballpark. That's a list we're looking at. I want to say something about the complex, I'm sorry to use this term, but you'll know what I mean, the diagnostic profile. These youth and emerging young adults in some cases, right, because they're turning 18, have really complex needs. And really, I do want to say, one of the complex factors is how many of these young folks have autism. And I want to say this out loud because just to refresh everybody's memory, we only began the autism benefit in the state of Georgia in 2017. That is a network that is still in its infancy stages. This is important, and this is a really critical workforce shortage area. So I know some of the live cases that we are working on right now are in fact really hustling to find some things which frankly don't yet exist in the state, partly because of workforce challenges and partly because we are in the very early stages of this. Where there are mental health needs, behavioral health needs, or individuals who have an intellectual and developmental disability and may qualify for our waiver, we are actively involved in what can we do from getting them to an improper situation into working to make sure they are eligible for any services that DBHDD has available. So that's my short answer, but there is very active work around these actual individuals right now as we speak.
The only thing I would
Oh,
add,
please.
I'll just
Yeah,
add
thanks.
one thing to
Yeah.
that is we want to be good partners and we want to be collaborative. And so one of the things that we put in the spend plan, you'll
yeah.
see it there, I flew by it, was the DFACS liaison position. So we funded through the supplemental funds a liaison between our two departments. We think that linkage will work well. We've seen some examples of that long time ago. And we have a similar position like that with the Department of Education. So we are using this to pilot what that could look like to help with some of the coordination.
For the benefit of the committee members, Chairman Dempsey went with several of us to youth villages. That's probably the most intensive psychiatric bed hospital for children. They have 75 children, fewer than a third of them are Georgia children. They're all out-of-state children. And that was a surprise to me. Youth villages, only a third of their population, they have about 75, correct me if I'm wrong about these numbers, about 75 children, beds there, and fewer than a third are Georgia children because our quote reimbursement rate is much lower than Tennessee, much lower than other states. And so we're looking at these very intensely involved children that are in hotels. we have a good facility, one that has a good reputation over time for very complex cases where, and I think of those 20-something children, there are only 7 were foster care children. So I'm trying to figure out, that was a very little bit unnerving to me.
It was, as well as the fact that then our children are being placed out of state or in hotels. So that is a
Hotels.
challenge that I think we need to
Ag-
focus
ag-
on.
Agreed. And let me say for this one in particular, our partnership and relationship with the Department of Community Health is who would oversee that rate structure. We are in active dialogue with them about what we give input into is the areas in which we have expertise, what we think is needed, what that might
I'm
cost.
hoping active dialogue means that you're telling the OPB that we're losing money to out of state based on inability to fund these beds. The same children are in the hotels.
Yeah, I can tell you, I've actively participated both in conversations and in site visits to some of the other. So I want to just, again, whenever we use acronyms, PRTFs are those psychiatric residential treatment facilities that Representative Aller is referring to. And they are a critical asset in our state. And they each of them do specialized work. And yeah, so getting on the ground, seeing what's possible, and then you all being aware, because I do think this is important. We have children in Georgia to serve, and those entities want to serve Georgia children. So there is critical work ahead. And again, our partners at the Department of Community Health are undertaking that work right now around the rates. Another question?
Okay, thank you. We do. Representative Benton, I believe. No, Barton, I'm sorry. Sorry.
I just have a simple question. Listening to what you said with the whether did the block grants and stuff, but did the American Recovery Plan give you 4 years? Just looking at your timetable on the chart here, do they let you have a little bit longer to not have to do it in 2-year plan?
No,
Okay.
they're both 2-year plans.
Okay.
CARES and the OPER are both 2-year each. They're just not the exact same start and end 2-year period.
Okay. I apologize for being late, but I was listening on Zoom on the way in. So
That's impressive. So thank you. And you made me nervous anytime someone says there's a simple question. I feel like it's about to get dicey in here, but
that was a simple question. Though.
I know we've handed you a lot today. Chair Dempsey, you know we have a willingness to come back after you reflect on this, continue to answer more. There are other aspects of DBHDD business that you also may have questions about. We want to be as transparent and responsive to your questions because you all have made it clear that the people we serve, some of Georgia's most vulnerable folks, are a high priority, and we're grateful for that attention. We want to do everything we can to tell you what we're doing and then learn from you what you're hearing and what your priorities are. We'll continue to do that. So we want to be available.
Thank you so much. I mean, this was great. And I know we have crammed a lot in pretty quickly this morning before we jump into session here today. I do think that we need to consider coming back and having some more dialogue about this before session starts. This is so important. And now I think we're very cognizant of the fact that it involves not just your agency, but so many others pulling together and working together. And so I hope that we can find a time for that. I know we're getting ready to go into a busy holiday season for many of us, but this is a priority, and I want us to be well informed and well equipped as we go into this next budget cycle. In the meantime, to the committee, I want to say thank you for being here early this morning. It's not as early as some meetings, but I do appreciate y'all making this a priority in your day. And also just to make you aware that Michael Polachek, who we all know so well, is also our liaison to work and to contact DBHDD in any way, and very, very open to it as well as Ashley. But Michael is just ready on the spot to find any answer that you may need, whether it's a request locally of something that someone needs or the bigger picture of some of this. So we will continue to work on this. And I thank everyone. Not seeing any more questions. We're adjourned. We'll all get to work, and I know that y'all need to too. So thank you.
Thank you, Chair Dempsey, and members. We appreciate your champion efforts too. Thank you.